He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Folks, you have found the Stay Off My Operating Table podcast with Dr. Philip Ovadia, and we are joined today by Dr. Nasha Winters. I'm looking forward to this conversation because, for a lot of reasons, I'm not going to spoil it, but I think this is going to be a good one.
I know this is going to be a good one, and I'm looking forward to this because Dr. Nasha Winters is awesome. And I finally had the chance to meet her in person. I think it was at the Maha Ball, if I remember correctly. I was trying to remember where we crossed paths, but known of her work for quite a while and really interested to talk about her perspective on metabolic health and cancer, which is her area of focus, and looking to get into that. Nasha, why don't you give a little bit of your background, introduce yourself to our audience?
First of all, thanks, you guys. I'm excited to be here. Dr. Phil, I've been following you forever. So it was really fun to make your acquaintance more in person at the Make America Healthy world as we're seeing what we could do on our part of that. But my world started as a cancer patient. I guess that kind of jumps right into the story there. Oh my gosh, we're coming on 34 years ago. I was 19. I was misdiagnosed for months on end from a lot of health issues that were kind of a continuation from my youth. And by the time they figured out what the heck was going on, it was too far gone. And I was too sick to even have a single dose of chemotherapy. So I was left to my own devices, sent out to pasture, given just a few months to live. And here we are over 3 decades later. Yeah.
Well, it's been great talking with you. Yeah. Oh, wait, I'm guessing there's more there, Phil.
A little bit. And it's funny because I was pre-med. That was the plan. I was heading in that direction. And because I was sort of dropped like a hot potato from standard of care, it pushed me into a different realm. Nothing was being able to help me from that. So I started looking into alternatives. And honestly, I didn't think I'd fight it or survive it. I just wanted to understand it. I'm curious by nature. I'm still a scientist by nature, even though I went down more of an integrative alternative role. But that's what I've spent my last 3 decades learning, is just the why of my cancer process, but also the why of the, tens of thousands of patients that I've helped directly in their cancer process to understand the why. And that's what's landed me into starting to understand cancer more as a metabolic mitochondrial disease over one of genetic origin. And so for me, when I was given that time, I was sort of sent down some crazy circuitous paths. And one of them, which is a really good place to start, because I think this weaves all the metabolic world together, is I had a 100% bowel blockage. And so I couldn't eat. And that's actually probably what saved my life.
Wow.
We didn't know what we know today, what I was applying back in 1991, which was deep water fasting, which even from the work of Dr. Moreshi from the early 1900s showed that alone could debulk a tumor, so make it go a little smaller, which it gave me enough relief that it stopped pushing pressure on my ureter. So my kidneys started to work again. It stopped me trying to put more stuff in a tube that was blocked, so that could resolve on its own. It helped dry up all this fluid that was filling up my body parts in places that it didn't belong, known as ascites. And it helped take away a lot of the pain that I was enduring at that time and the nausea. And so for me, it was probably this beautiful accident that left me moving down a pathway to understand the why of cancer from a different perspective than what we were all learning in school at that time.
Yeah, let's maybe go through this a little bit. So you're a pre-med student, you're thinking you're going to med school, going to become an MD. You get this, it sounds like you have a little bit of an adventure with the medical system, as unfortunately too many people have had. And you get to see sort of the inner workings of it. And how did that, before maybe we get into the specifics of, what went on with your cancer, how did this experience kind of change your thinking about the medical system and what you wanted to kind of, your career path from there?
Yeah, that's actually a really great question. I will tell you, I was pretty disenfranchised there for a bit. I was frustrated, to put it mildly. I had kind of a lot of love loss and a lot of trust loss in the system. And when I actually decided I wanted to go to naturopathic medical school, I could not get my professors to write me a letter of recommendation. because they all told me that I was too smart to not go to medical school, that I was wasting my time, wasting my career, that they basically wouldn't condone me going into Quacksville. So I was met up, and this is the early 90s, I was met with a lot of resistance. We'd only newly had the Office of Alternative Medicine part of NIH at that time, which was probably like a $3,000 a year budget or something ridiculous at that time, and still very fringe. But I was also still very much a scientist, and I was at that time dating, now married to a crazy biochemist who actually went into cancer drug design. While I was in med school, he was in grad school. So our worlds always collided in sort of the basic sciences and the advanced sciences to even this, considered alternative realm, which funny that all these years later, things like biohacking and whatnot has sort of brought the science to the forefront, that maybe some of these crazy quack ideas from the naturopaths weren't too far off the bat. But it took me a long time, and I did get a couple of my professors to finally write me letters, one of which, ironically, years later, when I came back to practice in Durango, Colorado, I was his wife's doctor as she went through her cancering process. And so a full circle of how that came around. And he was my biochemistry professor. And what I learned from him with natural products chemistry and general biochemistry is actually still something that informs my medicine today. So it's kind of interesting that this one person who somehow believed in me or believed in that form of medicine, it ended up serving he and his family, really well in the future. But a lot of folks really wrote me off for it. And weirdly, all these years later, people will see the ND behind my name and think I lose credibility immediately. But I now train clinicians all over the world. 70% of them are standard of care doctors. About 20% of them are conventional oncologists. My job is to make them look better, right? My job is to make their outcomes better with the tools that I can bring to the table. And so I think we're making some room that I don't have to sit at the little kids, folding table at Thanksgiving dinner in the garage anymore. I think I get to sit at the big table now with my colleagues, and that we're respecting where our strengths and our weaknesses lie, and that we really are together integral to making a difference in our patients' lives.
Yeah, and I'm humble enough to admit that if you had asked me 10 years ago, I would have put you in that same bucket and said, not a real doctor and a quack, and what do you do? What is that? And maybe, because I know I was misinformed, ill-informed. Talk to people a little bit about what actually is a naturopathic doctor, what that training is, maybe how it differs from traditional medical school, and how that fits into, like you said, a holistic approach to health these days.
I love it. And there's naturopathic doctors that train all over the world, but in the United States and actually Canada, so in North America, we have very rigorous training. We have to have the same pre-med qualifications like you do to go to medical school. To date, we don't have the same USMLEs to get in, but they're still pretty rigorous. It's just as competitive now to get into naturopathic schools. It probably for
USMLEs?
Oh, that's like the science board or the testing that you have to do to basically qualify to apply for med school. Similar testing for going to law school.
Oh, like the MCAT, the LCAT.
Yeah, exactly. So sorry about the MCATs, like those. There's similar testings that get you pre-qualified basically. But I had to still meet the same prerequisites whether I was going to go to standard of care medicine or into naturopathic medicine. And then really it's a 4-year medical education, in-person medical education, and really you can't really learn the basic sciences any differently. Biochemistry, anatomy, physiology, pathology, microbiology, pharmacology, all of those basics, I would say virtually identical. Though we did spend, when you compare them, there's actually I can put this into your show notes eventually, but there's a comparison. We actually had a lot more pharmacology, biochemistry compared to our standard of care colleagues, because we really had to understand mechanism of action, pharmacogenomics and pharmacokinetics to understand how it interacts with other nutrients, supplements, herbs. We had to have a deeper understanding. Whereas in our nutrition, my God, I mean, we're talking hundreds of hours in nutrition, whereas less than 25% of medical schools even offer an elective in that. So we differ there, our foundations. Our basic sciences are virtually the same. We take the same boards to get into our clinicals. So you have to show that you're able to pass the basic science boards to make sure you can qualify for that. But when we get into clinic, I did rotations in hospitals. I did rotations in emergency rooms. I did rotations in cardiology offices, neurology offices. In Arizona, where I went to medical school, naturopathic doctors can give chemotherapy, deliver babies, and perform minor surgery. Medical doctors can do homeopathy, give acupuncture, and give nutritional advice. It's a kind of a rebel renegade state as far as a very broad scope of practice for many. So we all really infiltrated each other's tribes in a pretty beautiful way that we learned a lot from each other. And so I think that's the main thing. And then once I left school, I actually did a residency with a naturopathic doctor who'd been in practice for a while. And I did a residency with a neurology office and a pain specialist office with orthopedic surgeons. I almost became the first naturopath at an orthopedic pain hospital in Mesa, Arizona, back in the day up at Mesa Valley Lutheran. Jack, you might know of that hospital up the valley. So back in the 90s, I would have been their first naturopath, but they were going to pay me $15,000 a year to be an intern. I was like, my student loans are going to be, that's 6 months of student loan payback at that time. But really our training where we really differ is in our philosophy, our philosophical approach. And so I have to be able to speak the language of my standard of care colleagues, but I have to think about disease, more prevention as well as health creation, which is something where we might also veer off. There's not a lot of teaching of health creation. At least when I left naturopathic school, the medical doctors and standard of care were not being trained in health creation or medical prevention, disease prevention. I don't know if that's changed much today, but from the students that would come and do rotations through my clinic, both DOs and MDs and NPs and acupuncturists, it didn't seem like that was the case, just even a few short years ago.
Yeah, I would say sadly that remains the case. And, it might be given a little bit more lip service these days in sort of the, osteopathic medical world, but I don't really see that getting into actual practice much these days is the sad reality. And hopefully we're starting to see changes in that. Cancer, that's sort of the big one, right? Cancer and heart disease. And the real big bad diseases that kill more people than anything else. And, the traditional approach to cancer is kind of throw everything at it you can, try and kill the cancer. You might kill the host in the way, but, we have to sort of accept that because that's the only way to deal with this. Your approach, and I forget the exact term you said earlier, where you're fostering health, right? As opposed to fighting disease. And, in a lot of ways, like you alluded to, they're complementary, but maybe talk about, it's obvious from your story why you got interested in cancer, but talk about the how, because it seems like an area where there wouldn't be really much acceptance or room for bringing these sort of concepts in.
Well, it's interesting, back in 1914, Dr. Theodore Boveri coined the concept of somatic mutation theory, this genetic causation of cancer. And we were kind of off and running from that. But close to the same time in the early 1920s, another character by the name of Otto Warburg. If your listeners want to dive deep into this guy, hit the book by Sam Apple called Ravenous. Does a beautiful story about the sort of origins of metabolic theory of cancer in Otto Warburg. But his ideas came to fruition saying, guys, the gene is involved, but it's a downstream effect of an upstream effect at the mitochondrial metabolic level. And he was noticing that all cancers had this mitochondrial dysfunction in common, and that seemed to be where the problem started versus at the genetic level. Even fast forward, we actually put Dr. Otto Warburg's theory to test for a good 30 years before we stumbled across the helix, the DNA helix, and we kind of veered off the track again and moved back into the genetic world and have kind of been on, a brick on the accelerator pedal ever since. And yet, even standard of care oncology says that 5 to 10% of cancers at best are genetic in origin, which does not account to the other 90 or 95%, which is accounted for in the hallmarks of cancer and our research for this metabolic mitochondrial dysfunction. So all of our energy, all of our research dollars, all of our funding, and all of our medications and treatments are treating an antiquated theory unfortunately. What's really interesting is just a few weeks ago, Tom Seyfried and a few others came together and wrote a paper highlighting the fact that maybe we are finally seeing the metabolic mitochondrial theory of cancer is now shadowing the somatic mutation theory, because we've not been able to prove that the somatic mutation theory is at the crux of this. I mean, let's just get really simple, because this will tell the story of where we're going. If this was a genetic disease, we could remove the hard drive, the nuclei of a cell, of a cancer cell, and replace the nuclei of a healthy cell and turn it into cancer, or vice versa. That's never happened. That study has been reproduced all over the world many times over. It has never happened. But when you look more into the other organelles, specifically the mitochondria and even the cytoplasm in which those organelles move around, the environment is what makes the difference in whether we cancer or not, or whether we cover or not, or whether we can keep a recurrence or progression at bay or not. And so when I was going through my process, I was, of course, learning the somatic mutation theory. And to Dr. Phil's, talk, that the way we handled it then was this sort of napalm the field and hope for the best. We call it maximum tolerated dose. I started to run across the work of Otto Warburg. I started to run across the work of a woman named Mina Bissell, who's an expert in the field of extracellular matrix and basically tumor microenvironment. Her work in the 1980s started to inform me. I stumbled across the concepts of, like I said, Otto Warburg, to start to apply that to my own life and start to think about my own nutrition and my own cellular function or dysfunction. I started to run across the work of people like Robert Ader and psychoneuroimmunology and the role that stress and trauma and emotions have on this interface. I started to run across the work of people in the field of cytokines, tomato, and the role of inflammation in this process. And over about 3 decades, I started to realize that there's multiple drivers that cause these issues, which are very similar in the cardiology world. Stress impacts your cardiovascular health, sugar impacts your cardiovascular health, inflammation impacts your, virtually you start to look at this, they're all the same. Whether it's obesity, Alzheimer's, diabetes, cancer, cardiovascular disease, dementia, they all come down to the information that's going into those little mitochondria. So I tell folks the mitochondria do 3 things. They take in information, so light, water, air, nutrients, sound, emotion, physical toxicity, stress from the environment, stress from chemicals. It takes all that information in. It's like a repository. Then it translates that information. And it's, if the Google Translate's working well, it does a better job. If it's not, doesn't do such a great job. And it tries to make sense of all that information and discern patterns. And then its third major job is to send out communication or signaling into the system to tell surrounding, cytoplasma, surrounding organelles, surrounding cells, tissues, organs, structure, and even outside of that, what to do with that information. And so when we are putting in bad input, which we've been doing, especially in high octane for the last, since World War II, but we started making some of those changes really in the industrial food revolution, and even prior to that in the Neolithic farming era. Those were slower, more insidious changes, but we've made a lot of changes, a lot of new input in a very short period of time, and our bodies have not been able to adapt. And that's put a lot of stress on these poor little mitochondria that we've co-evolved with for 100 to 200,000 years, depending who you talk to. And now they're needing us. They were our survival for all these years. Now they're dependent on us to help them change the way they take in information, interpret that information, and communicate that information. And so that's what you and I get to do in the space of metabolic health. And whether you're focusing on cancer or cardiovascular disease, the input, the translation, and the signaling are virtually the same.
Okay, I've listened to medical professionals for the last almost 4 years have these conversations. And I'm now familiar with most of the terms and have what is probably a completely corrupted idea of what's actually happening down in the cellular level. Could you please now explain, like I'm 5,
Okay.
what you just said
Okay.
about the different perspective of cancer from what the dominant perspective is right now?
Sure. So the dominant perspective is that this is a genetic issue that is a malfunctioning or malreplicating gene that's either hyper turned on or completely turned off, and that it's simply a Russian roulette game and one of bad luck.
You got unlucky.
Yeah, exactly. And there's nothing you can do about it. And the only way we can deal with it is just to obliterate the environment and hope for something else to be standing. And hopefully it's the right thing standing at the end of the day. That's
So far, I understand you.
perfect. Perfect. The other idea is that the workings of our energy exchange, so energy exchange being ATP, which is just the currency of energy in our bodies, that energy is impacted by a lot of various inputs. So from the beginning of time, it was pretty simple. Air, water, sun, food, right? It's and wash and repeat. But over time, we moved from being kind of simple hunter-gatherers, completely in the flow of nature and the rhythm of nature that then synced with our nature as we became more and more modernized. So as we started to put down some roots about 11,000 years ago through the Fertile Crescent part of the world, throughout the Mediterranean region, we actually introduced new genes, new information at that time, known as the human leukocyte antigen. So, for what that means to your listeners is that we were cruising along and our bodies just didn't, like, it knew what to deal with the small amounts of input it had, it knew what to deal with. We were dying more of infections, of just like poor hygiene and misunderstanding, or being eaten by saber-toothed tigers, or really extreme environmental conditions. We were not dying basically at our own hand, okay, in our own diet and lifestyle choices.
With you so far.
Okay. So then we started putting down roots. We started changing things. We started adding foods and lifestyles that were different than what we'd been doing for tens of thousands of years. And that had an impact. It had an impact on our immune system. And so the HLA gene, when that showed up, that's the first time we started seeing things like autoimmunity, celiac disease, vulnerabilities to mold, vulnerabilities to infections, more so than we'd had in the previous 150,000 years. Okay, so that was a big kablam, but we had about 11,000 years to adapt to that, and we did. It became beneficial in some subtypes and detrimental in others. But in the Industrial Food Revolution in the mid 1800s, we changed things up again pretty rapidly when we started to mill salt, sugar, and flour and started to have transportation and getting access to things that we'd never been having access to.
Right.
Down the road, refrigeration. So suddenly that simple input in started to get pretty complex. So the analogy I like to think of is that at that time, we were probably not eating breakfast or hunting for our breakfast or having something that took an enormous amount of energy to create a breakfast, to walking down an aisle of hundreds of choices of boxes of cereal. That input is overwhelming to our genetics as well as our mitochondria. So it's like a genetic mismatch was happening, but the keeper, the protector of that genetic zone was even more overwhelmed and couldn't do his job as well as it could before. So suddenly we have new farming techniques, new factory techniques in food, more sugar than we've ever been exposed to. So in 1850, we averaged 5 pounds of sugar per person per year. Today, it's, depending on the studies, 145 to 175 pounds of sugar per person per year. That's a big change. We have the incandescent light bulb. We have the ability to travel into space. We have the ability to fly across the world, things that our genes and our mitochondria do not know how to cope with. And we're throwing, we only had about 60 to 80,000 new chemicals that have also come to the marketplace since World War II that have not been properly studied. So there's that input. We have basically a blanket of antibiotic poured over our planet known as glyphosate. And remember, our mitochondria are original bacterium. So now they're getting hit by something that is in the rainwater, the soil, the air. It's ubiquitous. You are getting exposed to things that your parents, your grandparents, your great-grandparents never got exposed to. And those mitochondria in the cancer world are literally suffocating. So respiration of our cells is being suffocated and turning into an ancient sort of stay alive mechanism, which is cancer. And it's going to unfortunately keep perpetuating the same broken cells over and over until the host is gobbled up with it. And so it's more of a race of when do we stabilize those cells and have them remember where they came from, versus if we just try to obliterate and kill those cells, we actually add more insult to injury. We add more damage to that mitochondrial milieu. And so it's a very different mindset, as you can imagine. I mean, Jack, you've even said you've been hearing this over and over, and still it's like it hurts the brain to think about. But simply put, we're putting a lot more information in that our body doesn't know what to do with. And in many of us, in fact, studies now suggest that 1 in 2 of us will meet a cancer diagnosis in our lifetime. So you flip a coin, and half of our bodies can deal with the burden, and half of our bodies cannot. So my job is to help people understand maybe some of the blind spots of what they're getting exposed to in, on, and around them on a day-to-day basis, that they may be able to take a bit more, control of and responsibility for that input and do
Yeah.
something with it.
Given that you're saying it's not a coin flip in terms of you didn't lose the lottery, it's not a genetic thing,
Yeah.
but due to the bad fuel that our mitochondria is getting, I hope I said that, it's a coin flip whether you'll get it or not, unless, I'm assuming you didn't say this, but there's an implied, unless we take steps to maybe,
Yeah.
I'm assuming, strengthen the mitochondria and
Yeah.
maybe do better with the fuel that we're putting in.
Absolutely, Jack. And I call it the terrain. So I'm a terrain expert. I'm also a tumor expert, but I'm a terrain expert. And I know, as being someone who stands before you, as well as hundreds, if not thousands of other patients just like me, that you can live very well with cancer and die of something entirely unrelated at the ripe old age of whatever. So creating a harmony within the environment shuts off the fuel sources to the cancer. And so instead of saying the cancer is the enemy, it must be, removed or radiated or, poisoned, you can do that in conjunction with saying, but let's also strengthen the environment around it so it doesn't lend itself to being cancer friendly. So we can really do both simultaneously, which is where I find we get the best benefit, by the way. You'll get the camp of totally alternative or totally conventional. You'll find that I find there's a time and a place for both to work very well together. But we really can do the best of both worlds, strengthen the environment in which the cancer took root while you do other things, whatever that may be, that's appropriate for that patient at that time, to also lower the tumor burden. And when you do those together, you have such a different outcome. That's when you have active cancer. Even better to clean up the terrain before you get cancer, because really the only cure for cancer is prevention. So I want people, but our human nature doesn't allow us to, somehow, not many people will make the choice to do something about it before it's a problem.
Yeah.
Most people will do something about it after it's a problem. So I'm speaking more to that population of once it's taken root, you are definitely more powerful and you've been led to believe, and you definitely have a bigger role to play in how this story goes.
Okay, that begs the question, and Phil, I don't want to trump all over you here, but there's a question out there just waiting to be asked.
Okay.
So let's
Yeah,
talk
I was gonna say,
specifics.
so let's talk about that balance, right? Because, many people, would have heard what you're saying. And like you said, they go to one extreme or the other, right? That, okay, we're not going to do any, we'll call it traditional therapy. I don't think it's a great term, but, we're not going to do any of the, let's just try and obliterate the cancer any way we can approach. And we're going to go to the all, sort of natural and support the environment as best we can. And there are other people that say that's crazy. You got to do all of the kill the cancer as best you can and cut it and radiate it and whatever else you can do to it. But you're advocating for a balance. So talk about the practicality of that. What does that look like when someone might come to you with, pick whatever common cancer you want to talk about?
I love it. I'll just use mine as an example because I think that's a really ripe one. So I'm 19. I'd had a history of irritable bowel syndrome, rheumatoid arthritis, polycystic ovarian syndrome, endometriosis, cervical dysplasia, all before the age of 16. Just so your listeners know, no one ever thought I was sick. I was captain of my volleyball team. I was student body president. I was top of my class. I was in honors classes. Worked 2 jobs. I was super capable, super going. But no one saw what was happening behind the Oz curtain, literally, because I grew up in Kansas. Extreme trauma, extreme abuse, extreme poverty. But I overachieved everywhere else to compensate for that. But no one on the outside world would know that. And there was certainly no way I was going to share that. It was definitely not a time to share those things. So at the time of my diagnosis, there was actually a lot of shame around it. Okay. But what I started to learn over time is that I didn't know what I didn't know until I knew. And all of my symptoms as a kid and into young adulthood were normalized. They're just like, there's a pill for that. Here, get on the pill when you're 9 years old to deal with your endometriosis. Here, go and cryoablate your cervix at 14 and again at 16 because now it's turning into cancer. Here, take this antibiotic because now you've got this infection, from your immune system not working well. Oh, and then take this antifungal because now you have like just the layer cake, but no one ever qualified it as something wrong or disease. It's just the way it was. All my girlfriends were like just being put up on all these different medications and all these birth control pills and all these things to deal with their symptoms, but it was all normalized. So by the time I got so sick, they just thought it was more of the same. And they literally missed looking for the zebra. So for me now, if I had me coming in, a 16-year-old me before I had cancer, I would say, why do you have all these issues? And I would start exploring. So that's where a methodology is very important because we tend to jump right to protocols in medicine, which I think is it's missing for everybody because then suddenly you're just layering. Like what was happening for me, they were all jumping to protocols, give this script. It's the same in naturopathic medicine. It's the same in functional medicine. Everyone just jumps to a protocol. They don't ask why. They might give lip service to why, but they don't really do it. So it would have been really easy to see that I had high insulin levels, that I was missing B12, that I had celiac disease that was undiagnosed, that I had no vitamin D levels. I had osteoporosis by the time I was 20, 21 years old. Like all these patterns because no one ever looked to see the leaky gut or the malnourishment or the abuse or the trauma or the things that were contributing to a very sick environment. So when we now have data that we didn't have in 1991, we have things like wearables, like HRV would have been really helpful, right? We have questionnaires like the Adverse Childhood Events Score. That would have been handy. I didn't learn about that till I was later in college in my pre-med psych degree. And so those were things that I started to learn. Wow, if I found out that a patient had a lot of trauma before the age of 18, they had more than 3 specific events, they have a much higher incidence of cancer and chronic illness. I need to start screening them sooner. I need to start asking more questions. I need to find out how they're dealing with that trauma and help them do that. We can see that those are the patients that have more endocrine dysfunction, more immune dysfunction, more metabolic dysfunction. So in my practice, I started screening my patients twice a year. We would do these labs that were these 9-hour health labs for $40. I could get their CBC, which is their complete blood count, their metabolic panel, CMP, a C-reactive protein, a TSH, and a vitamin D3. That's what I was getting then just twice a year for patients. And I would hit so many things off, had so many things off at the pass because I could see the beginnings and I had an A1C in there as well, the beginnings of diabetes, the beginnings of thyroid dysfunction, the beginnings of cardiovascular dysfunction. This is before we were even knowing about homocysteine levels, et cetera. So I could see these patterns and start to go, why? What's going on? And so that's evolved into a way that today in the cancer space, what would be perfect for me is every single patient gets what I call the onboarding labs, a really deep dive into labs that tell the story of their physiology and their biochemistry that they're not aware of. Because almost every patient will say to me, I was healthy until I got cancer, myself included. Yeah. Normalized illness so much that we even have our labs based on the average of the population, and we're a really sick population. So
good point. I hadn't thought of that one.
Right? So when we look and tell someone, oh, your ferritin is normal somewhere between 3 and 350, does that even make sense? So we're normalizing all those people who are poor perfusing, who are hypoxic, which will land in my space sometime because hypoxia really feeds into a cancer process, or the patients who have too much iron storage that are lending themselves to extreme oxidative stress, setting themselves up for dementias, liver disease, cardiovascular disease, and cancer there as well. But when we squish it in, we start to get a sweet spot of this is what you need to have your red blood cells function properly, and this is what you need to not kill your organs, right? Or feed oxidative stress. But we're giving this huge like normalization or like an insulin level. Are you kidding me? We today walk around telling people that a 15 is normal for an insulin, in the United States. I mean, that's just insane to me. So we've normalized so many things that
But
even
what would normal be? Remember, non-medical.
I love it. So I call it the power of fives. So if patients shoot for a hemoglobin A1C under 5, which is the average of your blood sugar over 3 months, if they shoot for an insulin under 5, all fasted, if they shoot for a uric acid under 5, which is a marker of fructose intolerance, a marker of oxalates, a marker of methylation and pre-diabetes, if you get that under 5, and if you get a GKI, which is a glucose ketone ratio, under 5, you don't see people like Dr. Phil and myself. And when we look, the average insulin in the United States is 15. The average GKI is somewhere between 25 and 30. The average uric acid is, I can't remember what Perlmutter in his book Drop Acid, I think he's saying it's around 7. The average A1C, we call pre-diabetic now a 5.6. I'm telling you, you're diabetic already when you get to that. There's no such thing as pre-diabetic. It's like being it's like being sort of pregnant. You either are or you aren't. And so we're normalizing and pushing. Actually, I think they're even saying 5.9 now is pre-diabetic, which is ridiculous because at that point you already have glycosylated end products rusting your innards and causing all kinds of issues throughout the body. So suddenly what we've normalized is stretching it out, that we're just allowing for sicker and sicker patients who just get this bill of health. Your labs are fine every year, and no one's actually looking at them under a fine-tooth comb. Yeah.
You're describing the shift in the Overton window, the medical version of the Overton window getting shifted well into the sick range and still treating it as if it's normal and healthy.
Yes.
That's something I never considered. Of course, I don't look at labs all day, so I don't know why I would know that.
But I love that analogy because that's exactly right. Everything has shifted so much that we don't even know what to do with it in medicine. So we just call it good and carry on. Dr. Phil, am I wrong?
Yeah, no, I mean, it's an interesting dichotomy, right? Because there are some things that we focus on in the medical system that we've shifted, right, lower and lower, more aggressively, right, that we call it a disease, maybe something like high cholesterol.
Correct.
And, that gets pushed lower and lower with the intent of basically getting people treated, right? Getting more people on pharmaceuticals primarily. And the hope is that's going to somehow improve things, and it never really does. And then you're right, on the other side of things, we've taken other markers and we've accepted increasingly worse metrics and don't call that disease because we don't really know what to do with it. Why call it a disease if we don't have a medication that's going to fix it, is a lot of what that goes into. But it is, interesting when you start to look at our medical system that way.
Yeah, it's definitely skewed. And so that first phase is to test. My methodology is really simple. Test, assess, address, don't guess. And the test is taking in data, right? So testing, imaging, blood biopsies, single nucleotide polymorphisms, the genetics of the epigenetics, what's been handed down from generations that you're born with, but that you have the ability to change its expression by your dietary and lifestyle intervention. So if you just say, my dad had diabetes and my grandpa had diabetes, therefore I have diabetes, that's actually not the genetics that are in stone, right? Those are the predispositions that may have some genetic underpinnings, but they're genes that you can change their expression. So we gather that information, we understand the biography as well as the biology of the patient to then elucidate patterns. That's the assess. And in the patterns, that tells us which are the main buckets being affected here? So is this mostly epigenetic? Is this a strong family tendency, high penetrance genes, they call them, that you do have a strong tendency toward this unless you do something about it early on? Is it their metabolic fuel choice? Are they feeding it tons of carbs? Are they feeding it too much crappy protein, like a really bad quality protein? What are they feeding it? Third, what are their toxicants? What are they putting on their body or into their bodies every day that they're even unaware of? Where do they live? Like their zip codes, are they exposed to certain Superfund sites or industries or water tables that may be quietly poisoning them? Microbiome, I mentioned already the glyphosate concern, which is now sort of just ubiquitous in our environment, but then everyone takes an antibiotic like it's willy-nilly, and just throwing that in there, and our animal sources are taking antibiotics. And so our microbiome has suffered, and a diverse microbiome adds to resilience and a strong immune system, which is the fifth drop in the bucket. Our immunity is really critical. We can actually test simple things like a CBC can tell us volumes about your functioning or not functioning immune system. The neutrophil to lymphocyte ratio is, when you do a PubMed search, it's the most prognostic for all-cause mortality. So your immune system matters if your own data is telling, your own researchers are telling you that, but we never look at it. Most of my conventional colleagues, much less my naturopathic colleagues, don't even know how to look at a neutrophil to lymphocyte ratio. And then we look at things like vitamin D, which now they're saying don't run. Just ignore that. The Endocrine Society, just ignore that. All right. Inflammation, which I'm sure Dr. Phil speaks about nonstop here, because that's such a driver in the cardiovascular world as well. Oxygenation also in your world. So perfusion and oxygenation is another big drop in the bucket. Hormone metabolism, not just are we excess or deficient in hormones, it's how is your body dealing with them? Is it just putting it into storage? Is it peeing it right out? Does it think that this message, is it bunged up messaging? Is there too many other things blocking the receptors that you can't get more hormones into it properly? And then the last two drops in the bucket are like your circadian rhythm and stress response and your mental emotional. So we evaluate for all those 10 sort of major drivers, and we see what the maybe top 2 or 3 priorities are, and then we address those. So specifically to whether or not we're going to use standard of care only or alternative only or a combination of the two depends on other data we get in the cancer world. So blood and tissue biopsies, pathology reports, something known as a Ki-67 score, which is run on virtually every patient, but most patients don't even know this is run. They don't know what it means, and most doctors don't report on it, which is a proliferation score. This tells you how fast is the cancer doubling. And chemotherapy and radiation only work, and targeted therapies only work on rapid, high turnover cancer cells. So a Ki-67 over 25%, if someone's telling me, I really want to do it naturally, forgo any standard of care, but if I see a high Ki-67 score, I'm telling them you're not going to do well if you only go natural. This little mother is fast. Let's head that off at the pass while we clean things up. The other side, though, is true. If I have a patient with a 5 on a Ki-67, you will make for a more aggressive cancer if you treat it with standard of care.
Oh, wow.
Yeah. Yeah. So that's the place of, here's a slow process, and you've now pissed it off, right?
Yeah.
Now you've made it mutate and turn to something faster. And that's what I see a lot of patients who come back to see me a few months or years later with a recurrence. When we got their original pathology back, we'd see that often, that they had low Ki-67 scores, and they literally created more mutations in their cancers and created more heterogeneity and actually created more difficult to kill cancer cells. So that's the place where we can strike a beautiful balance.
Question occurs to me there. So what you're saying is that these aggressive treatments drive mutations of the cancer?
Absolutely.
So so essentially what we're doing is we're killing the weak cancer cells and allowing the ones to survive be only the stronger ones that then reproduce. Am I getting that model right?
Jack, you're nailing it. And a great conversation to link to this discussion is an interview that Dr. Peter Attia did with Robert Gatenby from Moffitt Cancer Center about this emerging field called the adaptive theory of cancer, which is the idea, instead of the maximum tolerated dose, we push it back just enough so that the rest of the body can swoop in and do its job. When Dr. Rosenberg, who's another, he probably not know Dr. Rosenberg, Dr. Phil, he's in Florida as well, but he works part-time at Moffitt as well. He talks about these fast replicating cells are known as daughter cells in cancer. If we over harvest the daughter cells, if we take them down below, less than 20% left, you will wake up the stem cells, which is mama bear. And she's angry. She doesn't want to be woken up. When you do that, you've changed the cancer personality altogether and done exactly what you said, Jack. You've killed the weak, but strengthened the strong, the subversive. That's what happens all the time in standard of care, all the time. And it's so accepted that we just carry on as per usual. Here's what I'm trying to help people understand. You can bring the best of both worlds together. You can be way more refined and selective and specific and precise and personalized. And you can make both the terrain and the tumor do what they're supposed to do simultaneously.
I think we've reached the point in the conversation where we're either going to go way down a rabbit hole where I'm going to ask all the questions that are occurring to me, and we don't have time for that, or we lay the carpet out for how do folks who are hearing this and going, oh my gosh, yes, I need to know about this. My brother-in-law needs to know about this. My sister, I've realized here just in the last month, I've probably heard from half a dozen different people that they either directly or have a relative who just has a new cancer diagnosis. I don't know if I'm just more aware if there's more of it, but either way, what's a good follow-up action that somebody can take based on what they've heard here today?
My hope is that, first of all, something here spoke to them, that there's like elements to realize, wow, this is maybe not what I first thought it was. And maybe there's a little more hopeful message versus this is just bad luck. So I hope that's one take home. One place to start, and this isn't to be a shameless plug, but it's just helpful because it lays out in a very user-friendly, layperson way, the book, The Metabolic Approach to Cancer, which came out in 2017. There's really nothing I would take out of that book. There's a hell of a lot more I'd add in because the research is just adding to it every day. So that's a good place to start. There's a questionnaire in the book, but we'll give your listeners a link to a more expanded questionnaire that really weights it as well and gives it a score so they really know what their top 3 priorities are. So that if you don't want to ingest the entire book in one sitting, maybe just go to the 2 or 3 chapters that are more relevant to how you tested, so that you can start to become aware of, wow, I didn't know that about myself, and I didn't know about these tools or these different ways of testing or understanding. So that's a place to learn. And then Dr. Nasha, drnasha.com, will take you down the rabbit hole of lots and lots of conversations I've had with people like you guys and taken it, various angles. So if there's something that piqued your interest, you could probably put it in our search engine and find a topic that tickles your fancy. I also have my own podcast, which Dr. Phil and I are trying to get him on there so we can talk about the conversation.
Better do that.
We need to. Metabolic Matters is the name of that podcast. I've interviewed a lot of folks in all areas of metabolic health, not just oncology. And then on our site on Dr. Nasha, there's also a directory. I've trained now to date at the time of our discussion, nearly 1,000 clinicians and allied health professionals in 46 countries in this methodology. And we get about 30,000 hits a month of patients looking for someone trained in this approach.
Not bad.
So we really do have a need for more to be trained through this different sort of idea. But even in that group, we have a ton of conventional oncologists who are really appreciating that we're data-driven, we are personalized and precise, and we're also hopeful. We can do this better, a lot better.
Wow.
Yeah, and before we wrap up, let's talk about some of the innovative things that you're doing to really build a better system. This isn't just about sort of having a practice, which you don't actually have anymore because you're too busy doing much bigger things. So let's talk about some of those.
Yeah, thanks. We are building a data platform, which is a clinical decision-making tool that's also a repository where we can also do our research from. So we're collecting a lot of multivariant data points, and translating that and using AI, collecting in hundreds of thousands of cases and hundreds of millions of data points to make sense of those patterns more in real time. Because it's quite laborious, as you can imagine, to assess all of the data I'm taking in. And a lot of doctors, they just don't have the time or bandwidth. It's taken me 30 years to perfect that, where they don't have 30 years and our patients don't have 30 years. So we're creating a tool that's going to be, it's been being beta in our community for some time and really helpful, but we're hoping to get it out in more doctors' hands in the coming months. The other thing we launched was it's very difficult to find nutrients and supplements that are specific to the cancer population. There's so many great companies out there, but I'll look at the ingredients and be like, this patient really can't be taking X, Y, and Z because this can add to some proliferation potential of their cancer type or their metabolic type. So instead of that, we created a line that's just very specific to kind of the metabolic drivers of cancer, very high touch. Again, that has not been made available to the public. That was just for the doctors who got tired of trying to piecemeal together a lot of things for our patients and not being successful at doing it. So out of demand for our own community, and we're just getting ready to open that up to the community at large. We built a lab, which is just down the road from Jack, in the Wexford building in downtown Phoenix, which is an R&D lab, also a sample repository, a cell respiration lab. So we're actually looking at mitochondrial function in real time, and a metabolomics lab. So this is where we're innovating in novel delivery systems, novel formulations, novel combinations, even of nutraceuticals and off-label drugs in the cancer space specific to these particular patterns that we're elucidating. And then we're also, I got to walk the land this weekend outside of Tucson, we're building a hospital, 150 bed, 250,000 square foot integrative oncology hospital and research institute on a 1,200 acre organic regenerative farm. And we're hoping it's not just the hospital, there's a lot of other intentional communities being built up around it. And we hope that it is the sort of pilot of how to go back to a simpler time that our genetics can remember and that we can give our mitochondria a fighting chance and be a testing ground and a training ground for clinicians and for future hospitals like this around the world.
Wow.
Sorry. Yeah, a lot going on.
Wow.
Yeah, I'm sure I'm missing a few things, but those are the big ones. So thanks,
I'm
Phil.
so glad you're within driving distance too.
I know, right? You're close.
I'll come see you.
Please do. Please do.
Phil, once again, you blow my mind with the people you get on this show. This is fantastic. Our guest has been Dr. Nasha Winters. The contact information will be in the show notes, but the most important one, I think, is her website, drnasha.com, drnasha.com. Thanks for joining us. God, I want to have you back when there's more new stuff to report.
Love it.
And I just want to pick your brain about all kinds of things. So
It's here for the picking. Thank you guys for having me. It's an absolute honor.
all right. We'll talk to y'all next time. Looking forward to it.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Avedia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.